Tracy, we're ready for you to start.
Hi, welcome everyone. Today to our webinar, Applying SBIRT to Depression, Prescription Medication Abuse, Tobacco Use, Trauma, and Other Client Concerns. Today's webinar is presented by the BIG Initiative, the National SBIRT ATTC, NORC at the University of Chicago, and NADAC. Today I'll be your webinar facilitator. I'm Tracy McPherson. I'm a senior research scientist at NORC at the University of Chicago. If you have any questions or comments or want to know more about the materials you are shared with you today or about the BIG Initiative or our work with the National SBIRT ATTC, you are certainly welcome to email me at any time. We'd be glad to work with you to try to see if we can provide you some materials or information that you need. The webinar series is produced in partnership with many very wonderful and supportive partners that we've worked with for many years now. The Brief Intervention Group is the BIG Initiative. We have two initiatives. We have a Workplace and Employee Assistance Program initiative and a Hospital initiative. And we're going to show you some links to those initiatives and many, many resources coming up shortly. We also, our partner, NORC at the University of Chicago, is an organization that I work for and where the BIG Initiative is housed and supported, and the National SBIRT ATTC, or the Addiction Technology Transfer Center, which the BIG Initiative and NORC are partners in, and that is directed by IRETA, and our partner NADAC, the Association for Addiction Professionals, for whom Misty works with, and is a close partner in producing all of our wonderful webinar series that I hope you will take advantage of throughout this year. And this is our webinar series. We have on our website a downloadable flyer, which we welcome the opportunity for you to share, post, put in your electronic newsletters, on your websites, on your Facebook and LinkedIn pages. We have put together a wonderful lineup, and as you can see, the topics, many or sort of in a full range of topics related to screening and brief intervention, looking at specific settings around criminal justice. We have others that are specific to behavioral health conditions, like today's Applying SBIRT to Depression and Prescription Medication Abuse, Tobacco Use. We've already archived several that are related to opioid risk and also marijuana use. So you may want to take a look at those, particularly if you're interested in kind of a full range of substance use issues and the application of SBIRT to them. And then we also have been focusing on trying to share with you ways SBIRT has been integrated into nursing and in integrated behavioral health settings. So coming up in July, we have a wonderful speaker who will be focusing on integration of SBIRT in behavioral health and social work and talking about why integrated care. All of our recordings are housed on the hospitalsbirt.webs.com website, and you are welcome to share those with anyone. They are free education for anyone who would like to take advantage of those. To access materials for today's webinar and any webinar that we have produced in this series or will produce going forward, we have posted there all of the PowerPoint slides. We have tried to do our due diligence in getting materials that were referenced in those webinars, handouts, sample tools, protocols. You know, we really tried to house everything in one place. So we encourage you to access today's materials at our hospitalsbirt.webs.com website. For this particular webinar today, it would be /otherconcerns.sbirt.htm. So in addition to the PowerPoint slides, which are in PDF format, we will also post information about how to access the CE quiz. That's where the recording will be. And that's where you'll see where the free CEs and who the CE providers are for today's webinar. You'll also be able to ask questions this afternoon. We'll hold the questions till the end, but we really strongly encourage you to go ahead and post your questions as they come over in the pane typically at the right side of your screen. We call that a questions pane, and that's where you're going to be able to put in all of your questions. So whatever comes to mind, whether it's you don't wait to the end necessarily. We'll try to get to as many of them as we possibly can. If there's something that we don't get to, we welcome the opportunity for you to contact us and see if we could get some of your burning questions answered. And we'll probably leave about 10 minutes or so at the end for questions. So I'd say typically I start at the top and kind of look at what the questions are, so the early bird gets the worm. So we would encourage you to go ahead and enter them as they come to you. And on the technical side, we have Misty Story of NADAC. She's the Director of Training and Professional Development at NADAC. And Misty will be behind the scenes as you have questions about technology and other kinds of things. She will be our technical facilitator and our master of sort of solving whatever issues we can solve within GoToMeeting and GoToWebinar. So she'll be handling those things behind the scenes. And I just wanted to mention, we'll mention this again, is that after the webinar, we were going to send you a follow-up email, which will include links to the PowerPoint, to the website, to the CE quiz, to the evaluation, and so on. So we want to make sure we just point you to that now. We'll give you some additional reminders at the end. And just to stress that the evaluations and that piece of it is really, really important to us. So at the end, if we have a few minutes and we have time for you to go to the website and do some of that, we welcome you to do it as quickly as possible. It's really valuable in supporting our efforts to maintain our funding. So it's my pleasure today to introduce Dr. Rich Brown. Dr. Brown is a family physician and a tenured professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health. He completed college and medical school at Brown University, a family medicine residency at Overlook Hospital, Columbia University, and a family medicine research fellowship and master's in public health degree at the University of Washington. On the faculty at the University of Wisconsin since 1990, Dr. Brown's academic focus has been the primary care management of alcohol and drug disorders and other behavioral risk factors and conditions. He has conducted NIH-funded research, published dozens of peer-reviewed articles, made numerous presentations, and conducted workshops in the realm on 4 continents. He served as president of the Association for Medical Education and Research in Substance Abuse, or AMERSA, from 1997 to 99, and received AMERSA's McGovern Award for Excellence in Medical Education in 2002. From 1999 to 2004, he served as the founding director of Project Mainstream, a federally funded program that enhanced substance abuse education for 12 health professions and over 10,000 trainees. He currently serves as the director for the Wisconsin Initiative to Promote Healthy Lifestyles, which I fondly refer to as WIPHL, and whose mission is to enhance delivery of behavioral screening and intervention services in healthcare settings throughout Wisconsin. So my pleasure, Rich, to introduce you, and we will turn it over to you for your presentation.
All right, thank you very much, Tracy, and thanks to all the partners involved in making this happen, other folks at NORC, Misty and NADAC, and everyone at the National SBIRT ATTC. And of course, thank you for being on the line today and joining me for the presentation. I do need to emphasize that I do have a disclosure of a possible financial conflict of interest. I'm CEO and owner of Wellsys, a company that helps healthcare and workplaces deliver behavioral screening and intervention. But I do promise you that this presentation will be very evidence-based, and will do my best to keep it free of bias. So as you heard, we'll be talking about how to apply SBIRT, not just to alcohol and drugs, but a host of other issues. And I'll also be then addressing how these kind of services can fit into what people in healthcare administration are looking for these days. That'll be toward the end of the talk. So what I'll be talking about is what's the problem that healthcare settings, and especially primary care settings, are facing these days in terms of behavioral risks and disorders among their patients. We'll be talking about a possible solution to addressing those risks and disorders that I like to call BSI, Behavioral Screening and Intervention, which includes SBIRT. And then I'll talk about what research has taught us about the effectiveness and cost savings you can expect if you deliver BSI in primary healthcare settings. We'll talk about WIPHL's experience helping dozens of clinics in Wisconsin deliver these services. And then I'll also start talking about how we can expand the scope of BSI beyond some of the usual behavioral issues that people think about, and then talk about how this fits into the big picture of the healthcare environment. So first of all, what are the behavioral risks and disorders that we are challenged to address in primary care? And here you see them in front of you. We have over 20% of our adults in this country who smoke, a similar percentage who engage in binge drinking at least once a month. 9% are drug users, 7% are depressed at any given moment. And you can see the vast majority of American adults don't get enough fruits and vegetables, don't exercise enough. And actually current estimates are that over a third are obese. And so we know that these folks are at higher risk for injury and all sorts of chronic diseases, earlier deaths, and lots of additional healthcare expenses. And these days there's such tremendous focus on obesity. It's true that obesity can lead to a variety of important medical conditions, including heart disease and cancer. And so that's what most people are paying attention to. Unfortunately, the research is not very encouraging about what we can do for many patients with obesity and related problems with diet and exercise. Some studies have found that, yes, even brief advice can help patients increase their fruit and vegetable intake. Studies show that even the most intensive brief interventions can only get about 1 in 12 sedentary, healthy American adults to meet CDC recommendations about physical activity. So 11 and 12 continue not to meet those recommendations after an intervention. And for obesity itself, we see the best results if we can refer patients to intensive structured programs for at least 6 months, hopefully 12 months. And even when patients participate in those programs, on average, we only tend to see about 10 or 15 pounds of weight loss sustained. That is enough to give us slight decreases in blood pressure, improvements in cholesterol, slight decreases in glucose. But unfortunately, none of these services actually seem to prevent heart attacks or strokes, as best we know so far. And there is no evidence that there's any economic return on investment. In fact, a leading obesity economist predicts that obesity treatment will never actually save healthcare costs because the intensity and duration of services required to help people with obesity is just too costly. So speaking of costs, let's focus on what the costs of these risks and disorders are across the country. And so first, you can see the healthcare costs, and it's true that obesity is the leading behavioral cost generator. And altogether, these costs, these behavioral issues cost us well over $300 billion. However, if you add up the costs of the 4 other issues besides obesity, actually the costs are greater for those issues than for obesity. And as I'll talk about later, there's actually much more we can do. We have much greater ability to help people for those 4 other issues than we do for obesity, given our current research. Then there are additional costs related to productivity loss. Many of these costs are borne by employers, and you can see that these costs are actually much greater for tobacco, alcohol, drugs, and depression than for obesity. Then there are some additional social costs. And so between alcohol, drugs, and depression, those total about $100 billion a year. So altogether, we are talking about just under $1 trillion of costs every year, theoretically, which many of these costs could be avoided if we could more systematically address these issues. And again, the obesity costs are $220 billion total. But the cost of those other issues, which we know how to address better, are actually more than 3 times as great as obesity. So this is the kind of information I'd like to deliver to healthcare professionals to make it clear that we shouldn't just be preoccupied with obesity. There's a lot of other behavioral issues that we really need to focus on. These days, employers are being more proactive, making sure they're getting good value for their health care. And there's good studies that show us the cost of these issues for employers. So a study from Minnesota found that the average employer loses out on over $3,000 per year per depressed employee. Some of that's health care costs. Most of it is productivity loss. For each binge drinking employee, employers lose out on over $600 in a year. And for each employee who smokes, employers lose out on close to $6,000 a year. So employers are becoming more interested to make sure that these issues get systematically identified and addressed in healthcare settings. Now, obviously, tobacco use, particularly smoking, is a real important risk factor. In fact, it's the leading preventable cause of death in our country. It predisposes individuals to all of these health problems you see in front of you on the slide and many more. And of course, alcohol and drugs pose risks for a variety of health problems you can see listed on the left here. And then folks who just drink in an unhealthy manner are more likely to suffer from all of these issues. And a lot of people are surprised to see cancers on the list. And in fact, 11% of all breast cancers in the U.S. among females can be traced to their drinking. So perhaps if more women understood that, we would help many more women reduce their risky drinking. And then there are many conditions, maybe alcohol did not cause these conditions, but if patients with these conditions are drinking excessively, treatment for these conditions tends to be much less effective. And we have providers often not realizing that patients with these disorders are drinking heavily, and they're frustrated because their treatments are not working, they're ordering extra tests, they're trying other treatments, and it sure would make sense if we systematically identified whether patients had these issues. And then, of course, there's a whole host of tragedies that are much more likely to occur in people's lives if they are drinking excessively or using drugs. So, for example, in the top right, 69% of drownings involves alcohol and drugs, and you can see the percentages for other catastrophes in people's lives through the rest of the slide. And I want to talk a little bit more about binge drinking and drug use from the employer perspective. It turns out that across our country, 75% of binge drinkers are employed, and about 2/3 of drug users are employed. So contrary to popular belief among many employers, these problems really occur in all segments of our population, including individuals in the workplace. And many employers are surprised to find out that a significant number of their employees are affected by alcohol in the workplace. So on the left, you can see about 15% of a random sample of employees throughout the country admitted to drinking a couple of hours before work, drinking at work, or working under the influence or while hungover. And for about 5% of those employees, they admitted to this at least monthly and sometimes even weekly. On the right-hand part of the slide, you can see that a similar percentage of individuals admit to using drugs 2 hours before work or during work. And for about half of these individuals, it's more than monthly. So this clearly creates some risk in the workplace. Employers are so frequently doing all they can to make for safer workplace environments, reduce workplace injuries, and maybe not realizing the risk that employee drinking and drug use pose for injuries. And then real tragedy in this country is that of the 8.5% of Americans who have a diagnosable alcohol or drug problem, only about 10% have actually received help in the last year. So this is a tremendous treatment gap that I think it really behooves us to try and close. Now let me turn to depression. I think we all know that depression clearly creates a higher risk for suicide, but actually a much more common cause of death from depression is that people with diagnosed chronic diseases just cannot take as good care of themselves because of their depression. So we have many more people dying premature deaths from heart disease, diabetes, and other chronic illnesses. So that's a more important cause of mortality from depression than suicide. And there are other ways that depression can harm people in addition to just causing a much worse quality of life. I also, well, so far we've been talking about these behavioral issues in a preventive vein, but now I want to emphasize that with patients who have chronic illnesses, it's important to recognize and address these behavioral issues. So I'm going to show you the results of a national study taken from a claims database for dual eligibles. These are patients who are insured both by Medicare and Medicaid. So these tend to be low-income patients, most of whom are disabled or elderly. And the researchers were interested in what proportion of patients with these 5 fairly common chronic illnesses, high blood pressure, diabetes, coronary heart disease, congestive heart failure, chronic lung disease, what proportion of patients with each of those illnesses actually had a concomitantly diagnosed mental health disorder, alcohol drug disorder, or both. And they found that only a quarter to a third of these patients with these chronic illnesses had no diagnosed mental health or alcohol or drug disorder. About half of them had a diagnosed mental health disorder, most commonly depression, but other disorders were represented as well. Several additional percent had an alcohol or drug disorder, but no mental health disorder. And then another 10 to 20% had both a mental health and alcohol and drug use disorder diagnosed. So you can see patients with these chronic illnesses are the exception if they don't have a mental health or alcohol or drug disorder. And so often we're trying to improve disease outcomes for these chronic diseases. We're trying to help patients get their diseases in better control. And we're focusing just on the diseases, forgetting that the patient may have a concomitant mental health or alcohol or drug disorder, which is really complicating the situation and making self-management of those medical conditions more difficult, less effective. This has real important ramifications. So, for example, how many hospitalizations per patient per year occurs in these subgroups. So you can see for each of those 5 chronic diseases, if there's no mental health or alcohol or drug disorder, we see on average less than 1 hospitalization per year per patient. But if there's a mental health problem, we see a higher rate of hospitalizations, alcohol and drugs, higher. And both mental health and alcohol and drug problems, we see the highest rate of hospitalizations. So mental health disorder and alcohol or drug problem can increase the rate of hospitalizations several times over for these chronic diseases. And most of these hospitalizations, by the way, were not for mental health or alcohol or drugs. They were for getting better control of those chronic medical conditions. And so clearly this has cost ramifications. So we see here now a graph of the total cost of care per patient per year. So for patients with those chronic conditions, we see total cost of care between $8,000 and $16,000 a year. But for patients with mental health problems, we see higher costs, alcohol and drug problems about the same. But both mental health and alcohol and drug problems, we see much higher costs. So we see costs 2 to 4 times that of patients without these mental health or alcohol and drug problems. So this is a reminder that we need to address these issues not only to prevent problems in people's lives, but we have to address these issues in patients with chronic disease to improve their chronic disease outcomes. So I think all of this really reinforces the impression that healthcare settings really are flooded with these behavioral issues. They're important for predicting our ability to help patients enjoy favorable health outcomes, and they have important economic ramifications as well. So in summary, these behavioral risks and disorders are quite common. They're important determinants of health and costs, not just for healthy individuals, but for people who already have chronic disease. Yes, obesity is important. We need to figure out how to get a better handle on it, but tobacco, alcohol, drugs, and depression actually generate more than 3 times the cost of obesity. And these costs basically accrue to governments, which means taxpayers and employers as well. So there is stronger and stronger impetus for the healthcare system to better address these issues in a systematic fashion. So how could they do that? Well, the solution that I recommend is BSI, Behavioral Screening and Intervention. That involves screening patients annually for these issues. And in most cases, it's just maybe one or a few simple questions that can identify whether patients might have risk or disorder. If patients respond to those questions in a way that suggests low risk, we just reassure patients, reinforce their good, healthy behaviors, and we're done. But across the United States, most patients have at least one risk. When they are positive on that screen, then our next job is to administer additional assessment, usually several additional questions, which can help us ascertain the patient's level of risk or severity of their disorder. Now, occasionally a screen is positive and an assessment is negative, and that means the screen was falsely positive. That happens from time to time, and that's fine. We just reassure patients. The good news is most patients who screen positive are in an intermediate risk range, or if they do have a disorder, it's only mild to moderate. And the good news is that we can provide definitive care for these patients right there in the primary care setting, or perhaps in the emergency room or a hospital bed. But for patients who are in a higher risk category, perhaps they have a serious or severe disorder such as addiction or major depression, we certainly want to refer them for specialty administered services. And then it's important that we stay in touch with patients, provide follow-up and support, and assess whether the services patients have received so far are sufficient or whether more or different services are needed. So you can see this is a fairly simple concept. It emphasizes screening everyone once a year, and it emphasizes providing the appropriate assessment, intervention, and referral services for all individuals. Advantages we can expect, which research bears out, I'll discuss that later, are that we can recognize many more people with these issues when they are earlier. We can help people avoid complications. We can help keep situations under control, prevent progression to more serious disorders, and save money by avoiding the need for more costly treatment. So some examples of screening questions. A question on smoking is just very direct, whether people have smoked a cigarette, even 1 or 2 puffs in the last 3 months. The questions used for depression screening most commonly are the PHQ-2. PHQ-2 stands for Patient Health Questionnaire. So these questions get at whether patients have had, or how frequently patients have had certain symptoms in the past 2 weeks, little interest or pleasure in doing things, or feeling down, depressed, or hopeless. And so a certain combination of responses here would suggest that, yes, a person may actually have clinical depression and warrants further assessment. The alcohol screening question that is used most, as recommended by the National Institute on Alcoholism and Alcohol Abuse, is a simple question. In the past 12 months, how often did you have more than 4 standard drinks on an occasion if you're a man, or more than 3 standard drinks on an occasion if you're a woman? And we're careful to define standard drinks for patients as we ask the question. For drugs, a straightforward question like this one can be useful. In the past 12 months, how often did you use a prescription painkiller, stimulant, or sedative for a non-medical reason, or smoke pot, or use a street drug? And this differs slightly maybe from one of the questions you might have seen published in prior research. We've actually found that this language actually is a bit preferred and elicits more accurate information from patients. It's also a little less judgmental. And then we give patients a choice of responses, and basically any response other than never is considered a positive screen that would prompt us to conduct further assessment. Having the multiple choices here allows patients to minimize yet still respond positively. We found that adding a couple of additional alcohol and drug screening questions to the 2 questions I mentioned can actually improve the yield of patients we find who are using drugs. So these are called conjoint questions based on some research that my team did 10 or 15 years ago, funded by NIDA. And so one question is basically a question about whether the patient has ever drank more alcohol, used more drugs than they meant to in the past year. And then a similar question on cutting down, feeling they should cut down on their drinking or drug use. So any positive response to one of those questions would prompt an assessment as well. So we find that some patients who don't want to say yes to the direct question on drug use will say yes to one of these questions because of their drug use. So we find more drug users by adding these questions. And then we should be considering whether we should be asking questions on diet, exercise, and checking body mass index for obesity. Those are important health issues, and perhaps we can help some patients with those issues. Plus, we found that it's very helpful if we're going to be screening patients for sensitive, stigmatized issues such as alcohol, drugs, and even depression. It's helpful to have questions on more routine aspects of prevention so that patients perceive the questions as part of a routine health prevention routine rather than feeling singled out for stigmatized issues. And then the assessment instruments that we use, we can ask 6 additional questions, the Fagerstrom questions, to figure out how severely someone is addicted to nicotine. And the more severely addicted an individual is, perhaps the more important that they consider medications to help with nicotine withdrawal. The most commonly recommended questionnaires for alcohol and drugs are the audit and the DAS-10. But I actually prefer 3 other questionnaires for a couple of reasons. One is the audit, although is extremely well validated, the DAS-10 is not very well validated in primary care settings, and it actually contains some language which can be offensive or misunderstood by patients. Also, I find that it's not so helpful to give composite feedback to patients. So, for example, your audit score is 14. Well, 14 on an audit doesn't mean anything to patients. And that number could represent heavy alcohol use, it could represent lots of negative consequences of drinking, or it could represent dependent symptoms, or a combination. So the audit score is actually a very crude measure of several things that could be going on. Whereas with those 3 other sets of questions mentioned in the blue box, we can give patients particular feedback on the quantity and frequency of their drinking or drug use, on the extent to which their drinking or drug use is causing problems in their lives, and the extent to which they may have symptoms of dependence, have difficulty controlling their substance use on their own, and might benefit from referral to treatment. For depression, most individuals are using the PHQ-9 as an assessment instrument, and the PHQ-9 is especially helpful also as a measure of treatment response. So we tend to collect PHQ-9 data monthly on patients, and we'll come back to that. So here's how we have found it's most successful to do BSI in healthcare settings. In primary care clinics, we found it's best if receptionists can be triggered to recognize when patients have not completed a written screen in the past year, and receptionists say something like, "Would you please fill this out? Your doctor would like you to fill this out before he or she sees you today." And when patients are asked to complete the screens in that way, we get very few refusals. Then typically the medical assistant who checks vital signs takes a quick glance at the patient's responses to the questionnaires. And it's really key that there be a full-time individual to respond to those patients who screen positive, preferably see those patients at that visit. And when that's not possible, we can flag the medical records so the health educator will hopefully see the patient at the next visit. We found it just is not a very high yield activity to try and track patients down by phone if they don't get to see the health educator face-to-face. In emergency departments and other hospital settings, health educators can simply go around the units, introduce themselves to patients, and deliver services. And you may be wondering, is it really necessary to hire a brand new person to administer these services? And I answer very emphatically yes, and here's why. Basically, if we asked current physicians or nurse practitioners or physician assessments to spend just 5 minutes on these issues as they would arise in practice, it would take them an extra 2 hours a day. And that's basically assuming that the number of adult patients they see with these issues is reflected in the population prevalence. And remember, this is probably a conservative estimate because many patients are going to require much more than 5 minutes on each of these issues to get the best outcome. So at a minimum, it would be 2 hours a day, but it would probably be much more in reality. We also know that at those average 15-minute visits, when many patients feel rushed out of the room, the primary care provider is trying already to address 3 clinical issues. So if you think if they're trying to squeeze in an intervention for 1 or more of those issues, gee, they just don't have very much time. We also know that billing codes require that they spend 15 minutes on some of these issues so that they can bill. And if they're not going to spend 15 minutes, at least when it comes to billing, they may as well spend no time at all. Whereas a full-time health educator can spend the amount of time that's necessary both to get good outcomes and to generate billing. And as a result of this kind of analysis, there's more and more experts that are recommending that primary care providers delegate all prevention services to other staff. There's not even enough primary care providers to go around now, let alone to serve our expanding elderly population and expanding numbers of insured patients under healthcare reform. So it's real clear that we need to expand our healthcare teams if we're systematically going to deliver appropriate services to all the patients who would screen positive for these important behavioral risks and disorders. So part of what we do when we're working with clinics is help them select or hire individuals who seem promising. And once we've identified those individuals, we train them quite thoroughly over 2 to 3 weeks. And one thing we focus on very strongly is enhancing their skills in motivational interviewing. Motivational interviewing avoids a lot of techniques that healthcare providers tend to do by the seat of their pants that may seem like it would be effective, but it's really not, such as dispensing lots of advice and information that patients are actually not interested in. Scare tactics, coercion, shaming, guilting, none of those things works for the vast majority of patients. In fact, those tactics tend to elicit behaviors that make us think patients are in denial, make us think patients are resistant to change, when actually the majority of patients are ambivalent. And that's what motivational interviewing is especially good at. It's drawing out that ambivalence, helping patients recognize where maybe some missing information might be important in tilting the decisional balance and helping them decide they do want to make a change. But more often than not, it's not adding more information into patients' brains about these risks and disorders. They're already cognizant of a lot of that information. What's most effective is we help patients weigh pros and cons of changing their behavior in light of what's important to them in their lives. And studies show the more that we can get patients to make and strengthen their own arguments for change, the more likely patients will decide to make a change and the more likely they will succeed. So there's actually over 1,200 studies now in the medical literature that show that motivational interviewing is effective. And there's been some head-to-head studies that actually show motivational interviewing is more effective than other methods of promoting smoking cessation and reduction in risky and problem drinking. So we train our health educators very intently in motivational interviewing, and then once patients are committed to make a change, our health educators are well trained to helping patients design and optimize change plans. So we recommend that our coaches work through 10 possible elements of behavior change plans with patients, and patients may pass on various elements, but studies suggest that the more detailed the patient's behavior change plan is, the more likely they will be able to make and sustain behavior change. Now I want to talk about what our health coaches can do for depression, and that set of services is called collaborative care. Our health educators or coaches are not trained in psychotherapy or any form of counseling. That's someone else's job. But what they do deliver under this rubric of collaborative care is, first of all, they make sure that patients who screen positive on the PHQ-2 complete the full PHQ-9, which indicates the level of severity of depression symptoms. They can spend more time than I could as a busy family doctor educating patients about their depression and getting past some of that initial pessimism and instilling some optimism for treatment. They also do what's called behavioral activation. They help depressed patients engage in some behaviors that even without medication or counseling can start to lift depressive symptoms. In fact, researchers have found that behavioral activation is about 80% as effective as full-fledged cognitive behavioral therapy, yet behavioral activation doesn't take anywhere near the training and skill as full-fledged CBT. So we typically engage patients in 1, 2, or 3 of these behaviors, maybe exercising more, sleep hygiene, scheduling fun activities in their lives, socializing more, eating healthier, and perhaps engaging in some relaxing activities. And also the health educator can spend more time if there are any barriers to referrals, helping patients over those barriers so they can get medications and or counseling. They also proactively stay in touch with patients. They contact patients every 1 to 4 weeks depending on the severity of their depression. and work with them to engage them maximally in treatment, whether it's medications, counseling, behavioral activation, or all three. And they'll re-administer that PHQ-9 monthly to see how the treatment plan is working. Studies show if the PHQ-9 score does not drop by at least 5 points, then perhaps the treatment plan needs to be reconsidered. This is a really important part of collaborative care because one of the ways that primary care treatment of depression often is inferior is we often fail to recognize that patients are, who say they're improved are actually only partially improved. And this really prompts primary care providers to recognize partial improvement and changing the treatment plan to hopefully get complete remission. So there's actually 69 randomized controlled trials that have shown that patients who get collaborative care for depression plus their usual care do better than if they just get usual care. And there's actually several more studies now coming out that suggest that collaborative care can also help patients with a variety of other mental health disorders. Now, collaborative care has been designed primarily for primary care settings, but it strikes me that for patients who are receiving treatment in mental health care settings, collaborative care could perhaps be useful as well. And then in addition to motivational interviewing, change plans, collaborative care, health educators are equipped in advance with a database of referral resources so they can make effective referrals based on patients' needs, financial constraints, health plans, etc. And they are certainly inviting of follow-up sessions. Those are very important. And depending on the clinic and the health plan, those sessions could occur face-to-face or they could occur by phone. So that's what BSI is all about. Now let me tell you what research says about its effectiveness. So remember, here is a problem we're trying to deal with, and most people, unfortunately, are focused just on diet, exercise, and obesity. But BSI is actually most effective for smoking, drinking, drug use, and depression. And all I'll say about drug use for now is we have 7 good studies that show that BSI is effective for drugs. Not as much data as the other behavioral risks and disorders, and we don't have any data on the economic impacts, but so far the research suggests that BSI is useful for drug use, even so-called hard drugs such as heroin and cocaine. But now let's focus on smoking. So this is data taken from the latest federal tobacco cessation guideline, and there's a bunch of summaries of studies in that publication that tell us that on average, patients who are not screened, are not offered assistance for their smoking, tend to we tend to see about a 3% one-year quit rate among those patients. So that's basically the baseline quit rate, people quitting on their own without prompting, without any assistance. And that's great. A lot of people can quit like that. But if we screen and presumably offer more assistance, we can double that quit rate. And remember, this is the leading preventable cause of death. We certainly want to do all we can to help patients quit smoking. But look what happens if we not only screen, we also systematically offer optimal intervention services. Look at that quit rate. Almost 10 times the quit rate that we get without any screening whatsoever, more than 4 times the quit rate we get from just screening without optimal intervention. Well, what do I mean by optimal intervention? Well, studies show that it takes up to 5 hours of one-on-one counseling over more than 8 visits. And the previous study I mentioned shows that motivational interviewing can be helpful in promoting commitment to make quit attempts. The good news is physicians don't have to do this. Non-physicians can obtain just as good quit rates. But actually the role for physicians, NPs, and PAs is to prescribe medication or recommend medication because patients do best if they get medication plus counseling. So it's really a shame we know what could help so many more patients quit smoking, but I don't know of any healthcare setting. I've asked audiences of probably over 2,000 people by now if any of their healthcare settings offer these kind of optimal services, and nobody has ever said yes that they do. Real tragedy that we could be preventing so many deaths, chronic illnesses, and other suffering by delivering this recommended care. We can also be very effective addressing people's drinking issues. So remember, close to 1 in 4 of adults are in a category of drinking, a risky and problem category, that would suggest they would benefit by interventions. And the National Business Group on Health reviewed the over 50 randomized controlled trials in the peer-reviewed literature, and found that among these individuals, these risky and problem drinkers, we can decrease emergency room visits by 20%, decrease injuries requiring medical attention by 1/3, decrease hospital admissions by even more than 1/3, and decrease arrests and crashes by even more than that. So wow, I just get pins and needles whenever I talk about this. If you could imagine if we actually delivered these recommended services to the nearly 25% of adults in all of our communities who are drinking too much, wow, we could dramatically change the health of many of our patients, the family environments, improve highway and community safety by reducing crime and crashes. There's just so much benefit that would accrue if we would systematically deliver these services in healthcare settings. Unfortunately, we're not doing a very good job. The CDC found earlier this year that only about 20% of patients even have a conversation with a healthcare professional about their drinking in a particular year. And then collaborative care, the effectiveness of this for depression. I mentioned those 69 randomized controlled trials earlier. Folks next door to me here in Minnesota, next door to Wisconsin, have the most successful project getting services out in primary care settings. They have dozens of primary care settings delivering collaborative care. The reason they've been successful is they were able to strike a deal among healthcare purchasers, payers, and providers years ago so that collaborative care is actually a billable service. Unfortunately, in the rest of the country, it is not. But what they found is that for patients who just get usual care for depression, we see about 1/3 of patients at least half better 1 year later. But if patients get collaborative care, we more than double that. 70% of patients are at least half better 1 year later. And looking at how many patients are in complete remission 1 year later, only 30% with usual care, over 50% with collaborative care. So again, we know how to improve our depression care dramatically. It's sad that unfortunately it's just not happening. And there's been solid research on the cost savings that we could generate by delivering these services. So first of all, there's 2 major studies. One was actually a randomized controlled trial done right here in primary care settings in my home state of Wisconsin. And my colleagues found that we reduced the cost of health care by over $500 per risky drinking patient who received a brief intervention. And they'd only looked at savings from hospital admissions and emergency room visits. They probably would have found larger savings if they looked at other kinds of health care costs. They found for every dollar spent delivering these services, they saved about $4 over the next year. That is just such an outstandingly high and quick return on investment. The quickest and highest return on investment I know of any healthcare service. Another study in Washington State is done in concert with their SAMHSA-funded state-based SBIRT grant. In that project, the researchers looked particularly at a database of costs for disabled Medicaid patients in Washington State, and they found for each patient who received these services, healthcare costs declined by over $4,000 in the next year compared to similar patients who did not get these services. Again, just an incredible return on investment. For depression, the best study out there shows that an initial series of collaborative care visits and contacts cost $900, which is not cheap, but we save over $5,000 in healthcare cost savings over the next year. Another outstanding return on investment, but it takes a bit longer. And then for tobacco, it's a bit harder to do research on this because the greatest positive impacts of smoking cessation are seen 5, 10, even 15 years later when people who would have had heart attacks, strokes, cancers, lung disease just don't. But researchers have done projections and figured that the return on investment is even greater than BSI for alcohol and depression. It just takes quite a bit longer to materialize. So what I did is go back to the literature and look for savings not only relating to healthcare, but also in productivity loss, absenteeism, and injury. And so those savings are charted here for you. So you could see that study I mentioned earlier for primary care patients, $523 reduction in healthcare costs over the next year. A different study showed $1,200 improvement in productivity for employees. So per risky drinker, we see $1,723 in cost savings. And I did this analysis for, let's assume, a company of 100 employees. So we know that nationally 23% of employees would be riskier problem drinkers and candidates to receive these services. So we multiply the $1,723 times those 23 out of 100 employees who would benefit, and we get about $40,000 in savings for those 100 employees, 23 of whom are risky and problem drinkers. For depression, we see some significant savings in healthcare, productivity, and absenteeism. They add up to $2,100 per person. 7 out of 100 employees would be depressed in a particular year, so 2,142 times 7 is about $15,000 in savings. And then for smoking cessation, here the savings pertain to each extra quitter rather than each additional person who receives services. So we have about 20% of smokers. We can boost our quit rate to the point where we can get 5 extra people to quit in that year. Total savings per person, about $4,600. Multiply that times 5 smokers who we get to quit out of 100 employees, and that's $23,000 in savings. So altogether, we would help a company with 100 employees save over $77,000, or about $775 per employee. In Wisconsin, I share this information with lots of employers and also people who run employer healthcare purchasing pools. They are very impressed with these numbers. They've seen the research. They believe the numbers. And in Wisconsin, we have a substantial effort going on where healthcare purchasers now are going directly to healthcare providers, reminding of this information and asking them if they could do a better job delivering these services. And these cost savings estimates are probably conservative because there's a number of other kinds of cost savings that we could probably expect. We just don't have comprehensive enough research to demonstrate. But we know there would be additional savings from depression in future years, et cetera. So as a result of all this research, there's many organizations around the country that recommend that these services be delivered routinely. One of them is the United States Preventive Services Task Force. This is the #1 authority in the eyes of primary care providers with regard to preventive services. And then this other group came along. They were asked to study which of all the recommended services would actually be best at improving health outcomes and saving costs. And it turns out that BSI for tobacco and alcohol would improve health and save more costs than cancer screening, high blood pressure screening, cholesterol screening, or diabetes screening. So, and you know, if we didn't get those services when we went for health care, we would think that something is terribly wrong, yet we know that most people don't get the recommended tobacco and alcohol services, which would be even more effective and more cost-effective. There's many other national organizations recommend these services. ONDCP is the Drug Czar's office, by the way. Here are a few organizations in Wisconsin that recommend these services. The two on the left are those employer healthcare purchasing pools that I mentioned. Also, the state's Chamber of Commerce, WMC, the Medical Society, our umbrella organization for community health centers, and the list goes on. Everybody agrees these services should be delivered routinely, but they very seldom are. And so here's a bit of a laundry list about the benefits of these services. We know these services would improve health for patients. We know that if we can get adults to decrease their risky drinking or drug use or do better with their depression, there's going to be less stress at home, better role modeling for kids. We know that our highways and communities are going to be safer. For healthcare providers, other than helping patients avoid injuries, better prevent or treat chronic illnesses, there are some more selfish reasons that BSI can be helpful to healthcare settings. We can reduce the burden on providers who often feel overwhelmed and unable to respond to patients' needs. Increasingly, healthcare settings are called upon to meet growing numbers of quality measures, and some of those quality measures entitle healthcare settings to become certified as patient-centered medical homes and perhaps receive higher reimbursement rates from some insurance companies. And systematic delivery of BSI would fulfill about 40 of 150 of those criteria. We also know that for accountable care organizations, these services would generate lots of shared savings. So for accountable care organizations or ACOs, for every dollar that they can document that they've reduced healthcare costs, they get to keep at least 50 cents. So BSI would certainly be a winning financial proposition for them. Now for hospitals, it's a mixed bag because actually these services would result in fewer hospitalizations. So this would reduce revenue for hospitals. But on the positive side, it would address risk factors for readmissions. Hospitals are penalized by Medicare for high readmission rates. Also, getting patients to quit smoking or cut down on drinking weeks before surgery can improve surgical outcomes, and hospitals are increasingly held accountable for those. And working with others in communities to administer these services would meet ACA requirements for community health assessment and planning. And then, of course, for those individuals or groups who purchase health care, there certainly be benefits for them, lower health care costs, improved workplace productivity, fewer absences, fewer workplace injuries. The organizations that would benefit most would actually be our local and state governments, and most of us are probably paying taxes, so we certainly want our governments to be cost efficient. They would benefit because they are large employers, and they would also benefit because there would be reduced burden on law enforcement, courts, corrections, social services, and their healthcare costs. So there's so many reasons it makes sense to have healthcare settings systematically deliver BSI. And I would assert that this is actually the biggest step a clinic or hospital could take toward this triple aim we are all supposed to be working toward nationally of improving health outcomes in a way that enhances patient experience and controls healthcare costs. And so far, nobody has challenged me on this assertion. So that's this problem of behavioral risks and disorders that we face, the solution of BSI, the research on effectiveness and cost savings. Now let me tell you what we've been able to accomplish here in Wisconsin through WIPHL, the Wisconsin Initiative to Promote Healthy Lifestyles. It's been a really nice partnership between my organization, the UW School of Medicine and Public Health, also working with the Wisconsin Medical Society, of which I'm a member, and our state government's Department of Health Services has been a key player as well. The state received a state-based SAMHSA grant in 2006 that really helped WIPHL get off the ground, and that enabled us to work with dozens of clinics around the state to help them deliver BSI. Those clinics, with our help, screened over 100,000 patients, delivered well over 20,000 interventions. And we documented high patient satisfaction with these services, and we've documented favorable outcomes. We got the same reduction in binge drinking that randomized controlled trials tend to get, the same reduction that is necessary to generate the reduction in emergency room visits, injuries, hospital admissions, arrests, and car crashes that I discussed earlier. We also found we were able to reduce marijuana use by 15% of patients. And we did a little pilot study screening for depression and delivering collaborative care, and we found we decreased depression symptoms by 55% over 8 to 12 weeks. I was just amazed at that, and also the 4.9 out of 5 point patient satisfaction ratings we got from our patients. I asked our health educators, why do patients like this so much? And they said they especially appreciated the behavioral activation, learning what they could do to help themselves with their depression. And we have a study in progress now. We're putting the final touches on an analysis. We were able to obtain data from our state's Medicaid program, and we are finding that for each Medicaid patient who got screened during our SAMHSA grant, we reduced healthcare costs by over $1,000 per patient over the subsequent 2 years. And so we hope to finish these analyses off, make sure they are accurate within the next month or two, and then we'll be trying to get those results published. But this is, so far, is very good news to Medicaid. They're extremely pleased, and this, they're glad that this basically confirms their decision to allow reimbursement for SBIRT services when they're delivered by paraprofessionals like health educators. And some of these results, not the cost results, but the other results are written up in an article that was published in last month's American Journal of Managed Care. Now, you may be wondering, who makes the best health educators? And we actually had a bit of a natural experiment during our SAMHSA grant. We advertised for bachelor's level people, and we targeted the compensation level to those individuals but through much of our grant, we had the recession going on, so about a third of our health educators ended up being master's level counselors and social workers who were glad to work for bachelor's level wages. We also had a couple of high school graduates, and we actually found that they were difficult to train. They did not deliver services nearly as well as we would have liked. Our conclusion is we just do better with college graduates when we're trying to teach complicated abstractions such as those involved with motivational interviewing. Our master's level counselors and social workers, we also found somewhat difficult to train for other reasons. Many had set patterns of working with patients, and it was difficult to help them break those patterns and really deliver motivational interviewing with high fidelity. We also found that many of them quickly went off into dealing with other areas of stress and family strain and so forth, and didn't necessarily get back to the alcohol or drugs. And we also found when those individuals could find a higher paying job that allowed them to deliver psychotherapy and counseling, they were out the door and we had a retraining issue. So we did find that bachelor's level paraprofessionals who don't necessarily have any prior training or experience actually seem to make the best health educators, and our research found that those individuals actually elicited greater reductions in binge drinking than the master's level social workers and counselors. What kind of training and support do we give our health educators? Our initial training is 2 to 3 weeks. Some people say that's a real long time, but if you think about it, motivational interviewing, dealing with patients around sensitive and stigmatized issues, helping patients with behavior change plans, understanding some of the knowledge about smoking, drinking, drug use, depression, and so forth. There's really quite a bit of knowledge and skills that people optimally need to have. So when programs like this actually devote less time to training, honestly, I get concerned. And that, of course, pales in comparison to the years of training that we expect our clinicians to have. We have also found, though, that initial training only equips our health educators with basic skills. To help them become true experts, we found it's helpful to conduct weekly case conferences. We have them record audio tapes of actual sessions with patients with written consent, of course. We give them very detailed feedback once a month on their audio tape, and we're available for consultation as they need it. So we've documented that within maybe 9 to 12 months, we've truly made these health educators into clinical experts in these behavioral realms. We also help clinics. We guide them on workflow design, and we help them institute a quality improvement framework to maximize the proportion of patients that get screened and the proportion of patients with positive screens who get to see health educators and get additional assessment, intervention, and referral services. So that's what we've been able to do in delivering BSI for tobacco, alcohol, drugs, and depression, but we can and should go further. So with support from the CDC, the Centers for Disease Control and Prevention, under a grant to the University of Wisconsin, which came up or created this Transform Wisconsin project. This is a project that mainly endeavors to strengthen community-based prevention. We are the clinical prevention arm for that project. So we were charged with the task of helping clinical settings do a better job, particularly for patients with high blood pressure, diabetes, and high cholesterol. Could we help patients get better control of those three conditions? And this is very consistent with a national program out of the Department of Health and Human Services called Million Hearts. Their goal has been to prevent 1 million heart attacks and strokes between 2012 and 2017. And it turns out that one way to do that would be to help get better control, or help patients get better control of their high blood pressure, diabetes, and high cholesterol. Turns out that only half of patients with diagnosed high blood pressure have good blood pressure control. Same with type 2 diabetes. And only about 1/3 of patients with high cholesterol actually have good cholesterol control. So this and some other factors have actually generated over 200,000 avoidable deaths every year in our country, 3,200 of which happen to be here in Wisconsin. The map shows where the death rates or the avoidable death rates are higher. You could see that that's true especially in southeastern states. And this is a big issue for health disparities. So you can see in the middle of the graph the rate of avoidable deaths in blue for white men, in pink for white women, and to the left of the data on whites, we see higher rates for Native Americans and African Americans. So another advantage to delivering these kind of services. So our goal of this project, we call it CPEP, the Cardiovascular Prevention Enhancement Program, is to target these patients who have one or more of these three conditions, adults. And what we do is extend BSI, so we're screening, assessing, intervening, referring systematically for a variety of behavioral issues that are relevant to these diseases. And those behavioral conditions are depicted in pictures on the right. So we're addressing smoking cessation, healthier diets, more physical activity, weight loss for obese patients, medication adherence. We systematically identify patients who might be good candidates to take a baby aspirin a day. That's actually the quickest, most effective, and least expensive way to prevent heart attacks and strokes for eligible patients. And we also focus on reducing risky and problem drinking because too much alcohol can raise blood pressure and cholesterol and interfere with diabetic control. And we also focus on depression screening and collaborative care because, as I mentioned earlier, depression can hinder self-management of other chronic diseases. So far we're just getting started with this project. We're working with 3 clinics, and things are going very well. We're just starting to deliver services. And that perhaps foretells a bit about the big picture for the future. So let's talk a bit about the healthcare environment these days and what is increasingly expected of healthcare settings and how an expanded concept of BSI could provide some of the solution. So in the healthcare environment, they're expanding accountable care organizations and ACO-like contracts where we will increasingly pay not just for delivering services, but for improving patients' health. So different ways that healthcare organizations are having to think about delivering services, not just to see a patient, but to actually improve their health. And if you don't improve patients' health well, you don't get paid well, even if you've spent lots of time with patients. And this is going to create even more need to control costs because if an ACO in your community is able to treat patients better and at lower costs, they can then charge lower rates and they're going to steal everybody else's business. So the competition among ACOs someday I think is going to be very interesting. There's also increasing quality reporting requirements, as I mentioned. There's also more purchaser activism, more employers and government entities demanding better value for their healthcare dollar. We also have more competition for patients, such as all sorts of organizations now setting up urgent care settings and primary care clinics, competing and maybe skimming off some services from larger healthcare organizations. We also see more competition for primary care clinicians who, as I mentioned earlier, are in short supply. So if primary care clinicians are not going to be happy working for a certain healthcare setting, they may leave for other settings. And there's increasing emphasis on having patients satisfied with healthcare services and taking a patient-centered approach. So healthcare settings really face a tremendous combination of challenges. And so here's what I believe is a vision for thriving under accountable care to actually meet all of those challenges in a well-integrated fashion. And a large part of the answer, I think, is having an integrated system where we systematically recognize and address behavioral risks. We systematically do a better job with chronic disease management, as we're starting to do with the CPEP project. And we integrate also into that mental health and alcohol and drug treatment. And so this would help us deliver better care, do better on many quality metrics, get better health outcomes. We would save lots of healthcare costs by treating problems earlier, avoiding hospitalizations. We would certainly have more satisfied patients, and healthcare settings that do a good job would have a competitive edge with purchasers and be able to get more and more contracts. And I firmly believe that this kind of integrated approach to these behavioral issues and chronic disease needs to take place in primary care settings. Why is that? Well, for one reason, patients are already there. We know that when we try and refer patients elsewhere, whether it's for mental health services, alcohol or drug services, and sometimes even for specialty medical services, for one reason or another, many patients just don't make it there. So if we deliver these services in primary care settings where patients already are coming, we know they're comfortable, we're more likely to be able to deliver them. We already have trust and rapport with patients. There's less stigma about coming to primary care settings for these services. And if patients maybe are not keeping appointments for some of their preventive services or mental health or AODA services, we're probably going to see them somewhere down the line for something else like a sore throat or a sprained ankle, and that's an opportunity to re-engage them in those other services. We also by doing this in primary care, we can help improve things for primary care physicians or other providers who often feel overwhelmed and unable to respond to patients' needs. So we can also empower them to be the captain of the ship or to be a team leader and really have the resources to address all these needs that they feel they can address now and make them happier to continue working as a primary care provider. And also, I think it's important that there be one person held ultimately responsible for patients' health outcomes. Once you have more than one person responsible, things aren't going well. It's hard to figure out who to focus on to improve things. And this would really best maximize integration of care to do this in primary care. So this is actually my primary care provider right here in Madison at a UW Health Clinic. And actually, they are participants in our CPET program. So Pam, his medical assistant, has now been trained as a health coach. And you know, typically when we think of primary care behavioral health integration, and then we can include chronic disease in the mix, we think about what I like to call Tier 2 services. So we want to make sure that patients with mental health or alcohol or drug disorders are getting appropriate access to medications. We also want to make sure they can get appropriate services from various specialist programs, counselors, educators, and so forth. But what Pam is equipped to do is what I think of as a more basic level of service, the Tier 1 service, that she can respond to all of those patients who screen positive for these behavioral risks and disorders, including patients with chronic disease who have some risks, perhaps not taking their medications well, or they have heart disease and they're smoking and so forth. She can administer those brief assessment questionnaires, and she is well trained to deliver basic patient education, motivational interviewing to promote behavior change or commitment to change, work with patients around change plan. And for mental health disorders, she is well trained to deliver behavioral activation, other aspects of collaborative care, make those referrals, follow up with patients, make sure that they're participating fully in care. So that's what I'd envision, hopefully not just for the clinic that I go to, but for clinics across the country. And here's another way of looking at how this would work. So basically, we have a whole battery of topics that we talk to patients about. They're in the left-hand column. We certainly want to be talking with patients about their health-related and other goals in their lives. And also, here's a variety of other behavioral issues we could be screening for, but they're only going to be relevant for certain patients. And so the topics that we systematically screen for would depend on the patient's age, gender, and what other medical problems they have. So you can see for a well 15-year-old young woman, we would certainly screen for smoking, alcohol, drugs, and a healthy diet, make sure she's getting enough exercise, screen for obesity, screen for depression and anxiety, and trauma and violence. And if any of those screens are positive, certainly do further assessment and deliver appropriate interventions and referrals. For a 51-year-old male with high blood pressure or diabetes, there would be additional topics to screen for, and different topics to screen for in a healthy elderly woman. So this is how I believe we could much better systematize attention to these important behavioral risks and disorder, whether or not patients currently have chronic illnesses, mental health problems, or alcohol and drug disorders. Another aspect of, I think, what we need is we need consultants who are available not just to see patients, but consultants who, in a much more efficient manner, could just be providing guidance for that important primary care provider health coach team. So, for example, one element of collaborative care I didn't mention yet is it's helpful to have a psychiatrist reviewing the care of depressed patients and perhaps patients with other mental illnesses who are seen in primary care setting. So the psychiatrist may never see most of these patients, but they're overseeing care by reviewing the records in the electronic health record system. And they are triggered to review certain records, maybe risky clinical situations, maybe those patients who are severely depressed, or maybe patients whose PHQ-9 scores are not improving sufficiently, maybe patients with a history of a suicide attempt who are depressed. And they are discussing cases with the provider and the coach. They're available to do curbside consultations. Just take a quick call from the family doctor. Hey, I'm not sure what to do about this patient. Please help me. They can also serve as a buddy if the primary care provider maybe starts serving more complicated patients, and they can actually do some teaching. So one example of a way that we might want a primary care provider to start serving more complicated patients would be to actually administer medication-assisted treatment for alcohol and drug dependence in primary care settings. Perhaps some of you caught an article in the New York Times nearly a month ago which basically underscored a tremendous national quality gap. Less than a third of all people with alcohol problems receive treatment of any kind, and less than 10% are prescribed medications. And the 3 FDA-approved medications for alcohol dependence are shown in the right-hand part of the slide. And by the way, I have no economic interest in those medications. So if my primary care doctor, Adam, were to decide, okay, I'm going to get familiar with these medications, but I'd like to start using them, but I don't feel very comfortable, it would be great if Adam could know that there is an addiction medicine specialist who's available to take phone calls, reviewing his charts, and providing advice until he is comfortable prescribing those medications. Another slice of this model is basically involves looking at the health educator or the health coach as really the hub for all wellness, prevention, behavioral health, and mental health services in primary care settings. So they're responding to patients who screen positive with appropriate assessments, appropriate interventions, referrals, motivational interviewing, collaborative care, et cetera. And then one of the neat things is that when they are systematically seeing these patients and using motivational interviewing, they're much more likely to engage patients in some other referral resources that can help improve outcomes. And perhaps that can occur right off the bat, but so often patients feel they need to try to improve things on their own for a while, and maybe only at those follow-up visits will the health coach then be able to help the patient see, gee, it seems like you haven't really met your goals. Are you thinking there might be some other options? Maybe the patient is then willing, more willing than previously to get some help from other resources outside of the clinic, or maybe some of these resources are coming into the clinic, again, to make referrals even easier. So another ultimate way to look at this model, the patient and the family is always the center of our focus. It's not just the primary care provider, but it's now the coach who has a key role in dealing with all of the issues, and the coach is especially focused on the behavioral issues. And then there is a nurse, an RN at the clinic, who maybe is needed to educate patients on some more complicated medical issues such as diabetes and taking insulin, or maybe teaching an asthmatic how to use their inhaler, et cetera, et cetera. And hopefully there are more behavioral health specialists that are in clinic at least part of the time to be available for consultation and counseling and other services. And then there are the consultants, including the psychiatrists, the addiction medicine physicians who are reviewing records and in touch with the primary care provider and the coach by phone to optimize quality of care, even though they may not see most patients. And then, of course, there's all of the resources that we know are out there, but unfortunately there probably aren't enough of. And maybe by beefing up the services in primary care settings, we can help make more efficient use of some of these more specialized services accessible in our health system and our community. So in summary, behavioral risks and disorders are very common among our patients. They generate huge costs, not just in terms of dollars, but in terms of suffering for patients, other family members, other costs to communities, taxpayers. There's so much research showing that BSI would effectively address alcohol, smoking, depression, increasing evidence for effectiveness of addressing drug issues as well. The basic skills of BSI, including motivational interviewing, behavioral change planning, collaborative care, can be applied to address other risks and disorders so that BSI can be sort of the foundation for the Tier 1 services for patients who screen positive. And then we can expand BSI further to help with primary care behavioral health integration and patient-centered chronic disease management. So in my opinion, I think BSI would be a key way to help clinics and accountable organizations thrive in our changing healthcare environment. So at this point, I thank you for your attention. Thanks for sticking with me through this presentation, and turn it back to you, Tracy, to get some discussion and questions going.
Great. Thank you, Rich. What a terrific presentation and a lot of really rich information that you've provided today. And I imagine folks could go back and listen to this again once we've got the recording posted. There's just a real wealth of information people can benefit from. And so what I want to do at this point is just remind folks that we are going to have about 10 minutes or so of questions. And the questions pane, again, on the right-hand side, we already have a number of questions that have been submitted. So we'll start with some of those. If you have additional questions, please go ahead and put those into the question box. If we don't get to them, there's something that I or our team can answer, we will certainly try to get those posted. If we don't answer a specific question, you can email me, certainly, if you have a burning question. So let's start. There's a couple of questions, and I think you probably, talked about this already a bit, you talked about the qualifications of the person providing the BSI, and particularly using the skills of the health educator. And you talked a little bit about using those who didn't have a bachelor's degree and those who had more advanced degrees. And I think some of the questions are around, not only are there other specific credentials that one might need, maybe a certified drug and alcohol counselor, for example. And so do you think that there are specific credentials? And then I think there's a bit of a link being made between, is that necessary in order for them to be able to bill and be reimbursed? So can you talk about those a bit?
Yeah, great questions. And yeah, in addition to what I said before, let me emphasize a couple points. First of all, no, we really have not found that additional formal credentials makes a difference. And as I've talked about before, sometimes credentials can detract in a funny way. We've helped various clinical settings here in Wisconsin and other states hire or select probably a total of close to 100 health educators now, and we've seen how things play out. And what we've learned is probably the most important thing to look for in a prospective health educator are personal attributes. Is this the kind of person that's really projects lots of warmth, enthusiasm, energy? Outgoing people tend to do better than more introverted people. Is this the kind of person that really doesn't bring judgment or an axe to grind to the clinical setting? Are they willing to work with patients? Are they willing to respect patients who decide not to make changes that we might think are obviously needed at this point? So when we find people with those personal attributes, we find that patients warm up to them very quickly. We also find that they're a good fit for learning motivational interviewing skills. Now, the reimbursement question, yeah, that gets a little sticky. First of all, unfortunately, Medicare, you would think Medicare would be very friendly toward these kind of services because they're part of the federal government, which is pushing healthcare reform, and actually healthcare reform makes payment for these services mandatory. However, it doesn't make paraprofessional reimbursement mandatory. So Medicare actually is the least friendly payer toward paraprofessional administered behavioral screening and intervention. And they've heard from me and a number of others around the country that that needs to change. And but as we all know, Medicare is kind of slow to change. Now the reimbursement picture is quite different depending on what state you're in. In Wisconsin, we were fortunate to get that SAMHSA grant back in 2006, and the state was really a wonderful partner, and as part of state government that worked with us was also overseeing the Medicaid program. And the Secretary of Health Services at the time was very supportive, as was the governor. So we were able to get Medicaid to start reimbursing for alcohol and drug BSI when delivered by paraprofessionals. Now Medicaid is still a bit unclear whether they reimburse paraprofessionals for tobacco, but we've documented that most of our commercial payers will do so. Medicare actually will reimburse for depression screening, as long as, no matter who it's done by, as long as the credentialed provider, such as a physician, actually reviews the information and charts on it. However, as I mentioned before, there is not even a national billing code for collaborative care. So it's only that first depression screening that can be billed for. Any additional collaborative care cannot be billed. So yeah, that's a potential disadvantage to pay attention to when you're trying to hire. There are some states, for example, where they might reimburse if a master's level credentialed person delivers some of these services, but they will not reimburse if a paraprofessional delivers the services. Now, any question on reimbursement, we have to remind ourselves where we are in the evolving healthcare scene. And right now, fee-for-service reimbursement is predominant. But once we are in an environment where healthcare settings are being reimbursed for health outcomes rather than just service delivery, then fee-for-service reimbursement will be moot. And it won't matter who delivers these services. In fact, it will be best for ACOs to figure out who are the most cost-efficient people to deliver these services. Clearly, the answer is going to be paraprofessionals. And the cost savings and the shared savings that ACOs will generate will greatly exceed any dollars they could be generating by fee-for-service reimbursement. But yeah, unfortunately, we are not there yet.
Well, thank you. Thank you. And I think, folks, one of the things you mentioned about being driven somewhat by what state they're in. If folks want to email me and they're looking for information specific to the state, we're doing some work at the National SBIRT ATTC to try to organize that information and track that information, and perhaps we could connect you with the right people or get you the right information about what's going on in your state.
Thanks, Tracy. That's very helpful. If I could just add one more comment, if healthcare settings are waiting for ACO contracts to be predominant and only then they start trying to figure out how they're going to deliver BSI, it's going to be too late if their competitors have gotten the jump on them. So even though the reimbursement situation may not be very good in some states now, healthcare organizations of any reasonable size really need to start now figuring out how are they going to deliver these services, who's going to deliver them, how is this information going to be recorded in the electronic medical record, how are we going to educate our billing people, et cetera. There's so much that needs to be done, so much that needs to be learned in each healthcare organization about delivering these services. They really cannot afford to wait until suddenly ACO contracts predominate. Really, they need to get a jump and get started now, at least pilot testing these services in a couple of clinics, working out the kinks so they're really ready to go when the environment is more friendly.
Thank you. Thank you. There are a couple of questions that are kind of clustering around a common theme, and I think people are very appreciative of the research and the statistics and some of the information you shared around making the business case. I think that's really important for many who are trying to communicate the value of doing this, and in a variety of settings, folks that are working in hospitals and clinics, in employee assistance programs that are housed within hospitals. So there's kind of a variety of folks asking these questions. I just know that because I happen to know these folks. So when you talk about some of the references, some of the studies, like the studies that show some promising findings around drug use, are those some studies that we could perhaps get the references to from you? Also, or do you have any white papers or other kinds of resources we might be able to link to on our website that really help people make the business case?
Yeah, you can find some information at WIPHL.org. That's WIPHL.org. WIPHL is the University of Wisconsin-based program that I've been talking about. I can also send Tracy some of these materials, and perhaps we can email out some references to folks after the presentation.
That's great.
But
Yeah,
there are basically 7 studies that I know of that suggest that SBIRT for drugs is effective, but no studies yet on economic savings for drugs, unfortunately.
Right, right. Well, thank you. I know I've been to the WIPHL site before, and it has a lot of information, so we encourage people to go there. It looks like we're getting at the end of our presentation today, and so if there are some additional questions here I can answer behind the scenes, we certainly will do that. There are a few that I probably don't know the answer to, so if I can do a little research and get that, and maybe I'll email you, Rich, if you have time. That's probably how we'll handle a couple of the other questions.
Sure, I'd be glad to.
Great, I appreciate that. So just as a reminder, in our last few moments, the PowerPoint slides, the CE quiz, the recording, and access to the free CEs and the bodies that accept those CEs, that information, is all going to be posted on our website, hospitalsbirt.webs.com. And already Misty has posted a link to our evaluation of today's webinar. And again, I'd like to ask you if you have just a couple seconds to complete that now. We would be very grateful. Completing those evaluations is very closely tied to our ability to sustain our funding to be able to bring you this quality education and these well-respected presenters with incredible expertise is really tied to our evaluation. So completing that is really important to us. That's already over in your chat box. And finally, Misty will be sending you an email that contains a link to the PowerPoint slides, how to access the CE quiz. The recording will be available as well. She'll have a link to that. And it'll also have a link to the evaluation at that point again, and you'll get that within an hour or so. And then last but not least, just to remind you that this is part of our 2014 SBIRT webinar series offered by the Brief Intervention Group, the National SBIRT ATTC, NORC at the University of Chicago, and NADAC. And we encourage you to take advantage of our future webinars, including those that are focused on integrated care coming up in July and August, and to take advantage of the recordings that are available to you 24 hours a day. So again, I'd like to thank Dr. Rich Brown for a terrific presentation today. It's always a pleasure for me able to hear you present, and I'm sure I can tell by the comments and questions people really appreciate what you're sharing with them. And so thank you very much, and thank you to the audience for attending today, and we look forward to you joining us on future webinars. Have a good day.